not going to have enough time for a Kahoot today. We're going to be doing more. So we're gonna try a more challenging case, and it's a bit more complicated. The patient's a bit more complicated, and the second part of it is that it's not necessarily a chest pain case. It may or may not be on chest pain. So this whole idea, this whole program is a big experiment to see if we can teach you really the fundamentals of clinical reasoning. And once we do, can you apply that? And can you think through some of these problems, even if you don't have all the information you necessarily need, right? So what we're gonna do today is we're gonna all work together. I'll guide you through everything. You're not expected to know anything at all. And it'll just be more of a clinical reasoning exercise. The case that we're gonna be doing is one that I did actually see in residency. It was a very fascinating case, and it's the eventual process is something that you may not see in your entire career. Okay, so before we go ahead and get started, what I'll do, let me see here. I'm gonna just share my screen real quick, and for whatever reason, the chat here is not working, right? You guys don't see what I'm typing into the chat on Teams, right?
No.
No. Okay. So I think that's a problem with the settings on my Teams. So I got to figure that out. So for now, I do have the chat open on YouTube. So we're gonna just be using YouTube chat as if you need to say anything, if you don't want to speak up, you want to just type something out, you can put it in the chat on YouTube. Okay. And I can put if you actually just go to my to the YouTube channel, it'll be there. The live stream will be there. Okay. So let me go ahead and share my screen real quick. Okay, so here's the YouTube live chat. So I'm going to be monitoring it over here. And then the course is up, so you guys should be able to access the course. So if you go to the courses right there, it should be the first one, enroll, and then everything will be set for today. Okay? Sounds good. All right. Any questions before we get started? I think on YouTube there is a question about not saying 100% complete despite completing it. You do have to press complete lesson for whatever reason. So until you click complete lesson, you may not actually see 100% complete. And if you have any issues at all, just let me know. We'll figure that out. Okay. Other questions? All right, and I will be trying to call on you guys randomly, so just a heads up. All right. Okay. So, all right. So today's case is on a 66-year-old female who's presenting with severe back pain for the last 2 days. Okay. So already we're kind of seeing it's not our traditional chest pain case. Okay. It's located across the mid back, left side greater than right. So we're talking about right up here on this left side. That's my right side, but right here. She's been taking Tylenol and ibuprofen without relief. Any movement exacerbates her pain. It was severe on the drive to the hospital. It radiates from her back to the mid-abdomen and down into the pelvis. And it was initially intermittent, but now it's a constant pain. Okay, so Alexis, what are your thoughts so far? Just anything at all that you pick up from here.
Honestly, not really sure. I'm thinking so far, just possibly like a back injury already or something. Just 'cause it's getting worsening as she is moving. So clearly, it's not a minor injury, especially with the Tylenol and ibuprofen not helping.
Yeah, so she's doing something already for the pain. She potentially has a injury to the back. We don't know. We don't have that history yet, but it's a possibility. But yeah, so if you were to categorize this patient, just looking at this, it sounds like you're saying she seems like more of a sick patient, right?
I would agree with that, yes.
Okay. Prem, other thoughts?
So my first thought when I saw the movement exacerbating the pain and the pain radiation was a disc herniation. That's just my first thoughts and the first thing that I would want to rule out with an MRI or something like that.
Yeah, so if you have a disc herniation, you can definitely have pain that radiates down. And the reason why is you're basically your nerve is being pinched. The nerves will innervate everything below that level. So if she's at the mid back here, it'll shoot downwards. Usually you'll get some component within the legs, and it seems more that this is more abdominal pelvis. So it is a possibility, and we would want to keep it in mind. But yeah, so we're already talking about, okay, an injury, potentially musculoskeletal. Now we're talking about potentially a nerve impingement. So that's like the nervous system. And so Emma Garcia, what other systems do you think may be involved?
Nervous system.
Okay, so we said nerves, we said musculoskeletal. What else?
I don't know.
Okay. Let's see. I'm gonna stick with you for a sec, but I'm gonna stop sharing and then I'm gonna reshare my screen over here. Okay, so if you're not exactly sure, I want you guys to go back to the anatomy. Okay, so the anatomy will guide you. So if we're just looking at, we talked about muscles and we talked about I don't know if can you guys see that? Okay.
Yeah.
Yeah. Okay. Yeah. So we talked about muscles over here, and you can see my cursor, right?
Yeah.
Okay, so we talked about the muscles here. Her level of pain is like maybe about right in here, and it's going downwards, not necessarily into the back, but around the sides into the belly and down into the pelvic region. Okay, so it may be the muscles over here. We talked about it being potentially the bones and the nerves. So if it was something like a lumbar radiculopathy, if it were something like a nerve impingement like this, you would tend to have more of a sciatica, depending on the level of the nerve impingement. So the disc kind of herniates out, you push on the nerve, and it causes pain shooting down, right? Again, the radiation pattern is maybe not quite there. So we're talking about things in the back, right? We're looking at things in the back that could potentially be causing pain. But what if it wasn't just the back, right? Can you think of anything else that may be causing pain that might be associated with back pain?
If it's lower back pain, it could be, and like it's in her pelvic area, maybe something with reproductive or digestive if you go low enough.
Absolutely, right? It can be something in the digestive tract. It can be, if we're talking pelvic, it can be one of the reproductive organs for sure. Good job. Karen?
I'm thinking more like pancreatitis, maybe even kidney stone.
Okay. Okay. So now we're going into the abdominal cavity, right? So let's go abdominal cavity organs. All right. So we're talking. Where's a good picture? All right. This one's a decent one. So you said kidneys over here in the back. Then you have your pancreas up here. It looks like your intestines are kind of coming all the way around, right? The area where she's having pain, if you kind of, I don't know if you'd be able to see this one, okay. Maybe this one. The area where she's having pain, looking at it from the front, is maybe like around this region. So yeah, that pancreas is a good area. Potentially also the liver. So it's all a possibility. So this is kind of like the exercise I want you guys to go through, right? You have all these potential causes of pain, and you want to keep that differential broad. You don't necessarily need to go into actual diagnoses at this point, because you're just trying to figure out, okay, what can be affected, and then kind of narrow it down from there based off of her symptoms, right? So looking at the anatomy is always going to be super, super helpful. So let me see here, Jorge. So if you were to look at this patient, when you have a pain that starts intermittently but now is more constant, is that a pain that is getting better or getting worse?
If it was intermittent, it'd be getting worse.
It's getting worse, right? So so whatever process is going on, we have to be cognizant of that it is getting worse for her. Okay, so let me switch to the PowerPoint. Okay, so she's been unable to keep food down, secondary to severe nausea. She's been vomiting over the last week. She's had fevers that are not controlled with Tylenol or Motrin, so that's the ibuprofen. She has no new foods or travel, no sick contacts, and no blood in her vomitus. Okay, so any thoughts about that at all? I think Karen, your hand is raised still, so I'm calling you. I don't know if you just didn't lower it. Okay, Minal.
Can we be concerned about kidney stones?
Yeah. So a kidney stone, a lot of the times you will have some back pain. It kind of radiates over to the front of the abdomen. You can have nausea and vomiting very commonly. Driving around will cause pretty significant pain too, because you're just agitating that kidney that is inflamed from that stone. So yeah, absolutely. I would be thinking about a kidney stone. Other potential differentials, Emma.
I know this was already said before, but pancreatitis can kind of cause nausea and the vomiting.
Yeah. So can you kind of explain what pancreatitis is?
It's just inflammation of the pancreas, correct?
Yes. And how does that usually happen?
That part I'm unsure of. I do know though, one of my friends got COVID, and kind of a side effect from his COVID. I don't know if it was a direct cause, but he couldn't keep food down, and the doctor had said that pancreatitis could have been it, but I don't know the direct link between the two or what would cause pancreatitis.
Interesting. I don't think I've seen I'd have to look at that. But the most common causes of pancreatitis is one, a gallstone. So if you were to, switching screens is going to get so annoying so quick. So if you look at your biliary tree, right? So your liver is over here, and your gallbladder is right tucked underneath the liver. If you were producing stones in here because the bile is sitting here, you're producing stones. The stones can sometimes get lodged here in the outflow of the gallbladder, and that can cause cholecystitis where the gallbladder is inflamed. But if that stone is able to travel down and through the common bile duct going into the actual intestine, the small intestine. Sometimes it gets stuck right here, right where that tract goes into the intestine. And so all of the pancreatic enzymes, this may be a better picture. I don't know if that's a better picture. All the pancreatic enzymes drain in through this duct right here as well. So the enzymes are meant to digest things, right? And the pancreas is pretty well insulated unless the enzymes start spilling out into the actual pancreas itself. And so if you have gallstones stuck right in here, the enzymes start flooding into the pancreas. It starts basically auto-digesting the pancreas tissue, and you end up with pancreatitis. The other really common cause of pancreatitis is a substance that people use. Does anybody know what that is?
Alcohol?
Alcohol, yeah. So alcoholic pancreatitis is very, very, very common. I have patients that I would see pretty regularly because of alcohol use disorder that would cause pretty recurrent pancreatitis. And yes, like you guys said, it can cause nausea, vomiting. You have a pretty hard time keeping food down as well. If you're having fevers with pancreatitis, that is very worrisome because you're now talking about infection seeding into the pancreas itself. And infections in the pancreas can basically destroy your pancreas, and you can get very sick very quickly. You end up a lot of patients will end up in the ICU because of it. So yes, good job. That was a pretty good discussion about pancreatitis. Any other thoughts about this part of the HPI? Any other parts of the differential that you might be thinking? Yeah, Philip?
So she has a fever, but she hasn't had any new foods or traveled anywhere. It's kind of like confusing me. Like, I don't think it's any like infection.
Good. Yeah. So that's what you have to kind of look and see. Why is it that I'm telling you the information, right? If she has no foods or new travel, then less likely that this is the nausea and the vomiting is from an infection, right? It's not something that she ate like E. coli or salmonella or something like that gave her an infection in her GI tract. It's still possible, especially with her symptoms, but it's a little less likely, right? So if you're creating kind of like a rank list of your diagnoses, something, let's say like pancreatitis, because we talked about it a bit more, it's going to be a bit higher on your differential, versus a bit lower down is going to be something like a GI infection. Okay, so yeah, good point. Anybody else? Nope. Okay, cool. So let's go back. Okay, so the next questions we kind of already talked about. We already talked about our potential differential for nausea and vomiting with back pain and the likely systems involved. Any other ideas before we move forward? Cool. And I am still looking at the chat on YouTube, so if you do want to just not talk and put it in, that's totally fine too. Okay, so additionally, the patient states that she's had burning on urination as well as blood in her urine over the last week. She also reports a fever, hasn't been very well controlled with Tylenol or ibuprofen. She's felt very fatigued and has chills. Okay. She admits to dysuria, so that's just burning when you urinate, hematuria, which is blood in your urine, back pain, nausea, vomiting, fevers, chills, and abdominal pain. She denies any chest pain, no shortness of breath, no hematemesis, which is vomiting blood. Hematochezia is pooping out blood, and then melena is a type of stool that is like black and sticky. I'm not going to show it on the actual screen because it is a little graphic. Oh, my PowerPoint stopped presenting. Okay, so I'm not going to show it on the screen because it's a little graphic, but I will have you guys Google it yourself. It's kind of like a tar. It's very sticky, and it has a very distinct smell if you ever smell it in the future. And what it is your upper GI tract is basically bleeding. So the red blood cells in the stomach gets mixed with the acid, the blood cells break down, and then it causes you to have like this black residue. If you vomit that up, it ends up being coffee ground. It's called coffee ground emesis because it looks like coffee grounds when people throw it up. But if it goes down into the GI tract, it becomes this like very black, sticky substance. So I encourage you guys to look at it, but again, it's a little graphic. Prem?
Is it possible that the upper GI bleeding could be from the medication she's taking? So like from the ibuprofen?
Yeah, for sure. So so ibuprofen or any NSAIDs, non-steroidal anti-inflammatory. So that's your ibuprofen, naproxen, Advil, Aleve, or the Chem is another really big one. All of those can cause you to have gastritis and eventually ulcers in the stomach. If you develop an ulcer that bleeds into a vessel, burns into a vessel, that vessel can rupture into the abdomen, into the stomach. And if it's a very high volume that's coming into the stomach, you're going to be vomiting blood. That's your hematemesis. Well, we only have 5 minutes left in our scheduled meeting time. That's a mistake. We're not done yet. And if it's not a high volume and it's slow enough that it'll just trickle down and go into your GI tract, that's when you get melena. But I'm saying that she denies melena or hematochezia, so a little less likely a bleed right now, but it is possible. And you'd want to do a digital rectal exam if you're concerned at all. All right, so Jehan?
So the whole blood in her urine and the fact that she's having pain when she urinates, could a chronic kidney disease cause that? Would it be like a new onset chronic kidney disease, or would it be more so it wouldn't give her all these symptoms and it would be more so like the kidney stones that you talked about previously?
Yeah, so that's a good thought. So chronic kidney disease usually is not painful, right? So it's more, a lot of times chronic conditions that don't directly cause pain, they're not necessarily painful. And we think about things like diabetes or hypertension. Those chronic illnesses usually don't cause pain, but chronic conditions, but more acute conditions can absolutely cause pain. I don't know if I answered your question.
You did. Thank you.
Okay. And then there's some questions on YouTube. So people are saying kidney stones, GI, digestive tract. Would it be a digestive system issue because you can't keep the food down? Yes, potentially. We can probably rule out an intestinal perforation. I wouldn't. That's a good thought. I wouldn't rule it out as of yet. You don't necessarily need to have bleeding per se. You might not see the bleeding with a perforation as of yet. So and intestinal perforations are very severe, and you can have pretty severe pain. So yes. So if it's pancreatitis, would this affect her ability to produce insulin and glucagon? It would affect her ability to produce insulin. Glucagon, if I remember right, and it's been so long, it's more in the liver, so it'd be more insulin. So Tasha said a UTI probably went untreated. Yes, very possible. And Ursula is saying consider pyelonephritis. I think Nassim had her hand raised, and it looks like she may have been wanting to say the same thing.
Yeah, hi, Dr. Nakvi. I was thinking UTI as well, just because of the burning sensation while urinating, and then like the nausea, like the fevers and the chills.
So in a traditional UTI, right, if you have never had a UTI before, at some point in your life, most people will have one. But from what you know or from what you've heard, with a traditional UTI, do you typically get fevers?
In a typical UTI, I would say no, but I feel like if it's untreated, then it could lead to that maybe. Like if the infection goes past the urinary tract.
Okay, or not even necessarily past the urinary tract, right? So I think Ursel said pyelonephritis. So Nassim, do you know what pyelonephritis is, and would you be able to explain what it is?
I'm gonna assume it's inflammation of the kidneys or some part of the kidneys.
Yeah. So it's basically some type of inflammation of the kidneys. Usually it's because a UTI ascends the urinary tract. So it goes up the ureters and starts to affect the kidneys. So we're gonna switch the screen again. Let me see. So, and this is what I would encourage you guys to do. If you don't know about something that I'm talking about, just Google image, and there's a ton of diagrams that are actually really helpful. So pyelonephritis, this is a decent one. So this isn't a male because females don't have prostates, but if you have an infection here in the bladder, it can ascend up the ureters and into the kidneys, right? You can have an infection of the kidneys themselves, and that can cause pain in the abdomen. It can cause pain in the back because the kidneys are a structure that they're considered retroperitoneal. Not really important for what we are talking about today, but basically they're all that means is they're really far back in the abdomen, so they're more likely to cause kind of pain in the back as well. So absolutely. So if a infection in the bladder ascends up the tract into the kidney, that can that would cause a pyelonephritis. Okay, other thoughts that you guys might have.
Toxic shock syndrome. She seems kind of too old for it to be because of menstruation. But the symptoms kind of align with the syndrome.
So what is toxic shock syndrome, and how is it related to menstruation?
From what I know, from how it relates to menstruation is usually from an infection. Typically, usually from like feminine products if they kind of bear bacteria, and that can get into internal systems. But just in general, I know it's caused by some type of bacterial infection.
Yeah. So it's a different tract though, right? So it's usually because of a tampon. Pads don't typically cause this, but the tampon is placed inside the vagina. It stays in there, and if you don't change it out pretty frequently, the bacteria basically have a nidus to stay and cause an infection, and so it becomes kind of like a vaginal infection, but it's a severe vaginal infection where and I'm forgetting the exact mechanism, but basically toxins from the bacteria are released into the system, and it causes an overwhelming inflammatory response, and patients can be very, very ill when they come into the hospitals because of it. So absolutely. Let me see, there's probably a yeah, don't be toxic, right? This is an ad for why. And it was more common in the past. It's not as common now because of tampons. So yeah. Cool. Other thoughts that you guys have? No. Okay. So we can move forward then. Okay. So we kind of already talked about this, but what is on the top of your differential at this time? And I'll answer some questions while you kind of gather your thoughts. So what can an untreated UTI cause kidney failure too? Absolutely, it can. You would basically have to be pretty advanced, and it would basically be destroying the kidney. But if you have an overwhelming infection of the kidneys, it can still be transient, but it is very possible to cause kidney failure. Since there's also bleeding in her urine and pain around the area, maybe a kidney stone, yes. And so if you had a kidney stone, the kidney pain, the stones in the kidney themselves, a lot of times aren't very painful. People can have stones in the kidneys for many, many years and not even know about it, right? It's until it causes pressure in the kidney. So let me switch over again. So kidney stone. So if the kidney stones are kind of in this area, it's not causing an obstruction, then usually not a problem. But it's when the stone gets stuck lower down into the actual renal, this is called the renal pelvis right here, or even down further in the ureter. It's when that happens that it causes dilation in this system right here that it can cause pain. And as that stone travels down, it's kind of like it's kind of like razors just kind of shredding that inner lining of the ureter, right? Until you eventually kind of push it all the way out onto the bladder. And then for males and females, passing the stone, it can be pretty painful too. So, and this is kind of what a kidney stone may look like, right? They're not these small, round, soft pebbles. They're these harder, kind of jagged things, right? And they can be pretty small. They can be larger. So they can be extremely painful. Absolutely. Okay. So let me see here. So Christina, what is on the top of your differential at this time?
I was going to say a kidney infection as well. I didn't really have any other, I guess, opinions on what else. It just seems more like a kidney infection.
Good, good. And do you think that a kidney stone can cause an infection?
I'm not sure.
Okay, so I want you to think about it a little bit, right? What happens, just forget about the body, right? What happens if you have like, let's say you have a bucket of water and you set it outside and it's like halfway full. If you come back in about a week, what will happen?
It would be not dehydrated, evaporated, some of it.
Let's say it's cold, so it's not really evaporating. There's some rain here and there, so the water's just sitting there. What happens to the water? Does it remain clear and clean, or no?
No, it's dirty.
It's dirty, right? Same thing. Rivers in general are safer to drink water out of because the water is running, right? The things are moving. It's harder for bacteria to seed in. So how does that relate to talking about kidney stones and infections? What do you think?
So since there's kidney stones, an infection could build up because your urine is not getting excreted from the body.
Exactly. So you're not moving that urine as much as you would if there wasn't a stone, right? That urine is free flowing. Not a problem, but once it gets stuck, because you're not moving that fluid, you're at a higher risk for a kidney stone. Now, thinking about that, who typically gets infections of the urine? Is it more males or more females?
I would say females.
Why?
I would say because they have their vulvas near their urinary tract, so they're more prone to infections. Close.
It's all about the actual ureter coming out, right? So in a female, that ureter is very close to the bladder, right? So there's not much that that the bacteria need to ascend into the bladder, or into that urethra, to actually get into the bladder and cause an infection. Versus in males, there is a much longer urethra that it has to ascend to actually cause an infection. It's still possible, right? But it's less common. And so that's why after intercourse, it's super important for any woman, and men too, but more so for women to urinate, to kind of flush everything out, because if you don't, you're going to end up allowing for that that bacteria to go into the urinary tract and into the bladder. So that's where you most commonly see infections, especially in younger women, just because that ureter is so small compared to that of males. Okay. Okay. So anything else that would be on the top of our differential? We can go with Elizabeth. Anything else that you can think of that would be important to rule out?
Not off the top of my head. Like everything that I go back to is related to a kidney infection.
Okay.
But I did have a question though.
Yeah.
So if somebody gets a UTI, and then I guess, can you have a UTI and a kidney infection at the same time?
Yeah. And a lot of times that infection is ascending, right? So the infection starts right here in the bladder, and it kind of ascends into the ureters, and it can come up and infect the kidneys. And if you have a stone in there, and you're not allowing for a lot of drainage of that urine, it becomes so much easier for that bacteria to ascend as well. So yes, it's very possible.
Got it. Thank you.
Okay. All right. Any other questions? All right. So let's move forward. So, and you can kind of put this in the chat on YouTube. Is this patient sick or not sick? What do you guys think? And somebody can shout it out. So most people, yeah, everybody's saying sick. Okay. Okay. So let's see. So she has a lot of stuff going on, right? She has this back pain. She has the nausea, vomiting. She has this urinary issue. So what do you guys think? Do you think everything? I guess the question is, do you think everything is related, or are these separate processes going on? Alyssa, what do you think? Related or separate processes?
I mean, I think they definitely could be related potentially, but
Okay.
I don't know. I think it could go either way, because I think there's like the kidneys have to play into like some factor, but I also like haven't forgotten about like the pancreatitis and like the potential like issues in the abdomen.
Yeah. So that's actually really perfect, right? Because we talked about the differential. I think a lot of people are kind of focusing on the kidney right now, but it's super possible, right, that she has a pancreatitis and she might just have a regular old UTI, right? That's possible. And if you're going after a kidney infection, you may miss something in the pancreas that can be potentially dangerous, right? So any other thoughts? Anything else that you guys think about? And I think there's a few people in the chat saying maybe different issues going on. One due to kidney issue. I think it could be either, but could also be separate trigger from taking pain medications. Absolutely. Could be related or not related. Test will help figure this out. Yeah, and even before the test, your physical exam will help you too. So the reason why I put this in here is because sometimes the most straightforward answer is the right one, right? Sometimes having the ability to kind of parse through everything and see, is there some way that all of these different symptoms are related to one system, is the right answer, especially if everything is happening so acutely and in the same amount of time, right? It's kind of like Occam's razor, right? If there is a simple explanation for what's going on, it's the most likely explanation, right? So would it be more common or more likely that this patient have lumbar radiculopathy, pancreatitis, and a UTI all happening at the same exact time? Or would it be more common and more likely that this patient has just a urinary issue that is infecting the kidneys, right? That's kind of like what the balance is. You don't want to necessarily rule everything out and say it's just that one process, but you want to keep those in the back of your mind. But you do want to make sure that that you're really thinking about those more common, I guess not more common, but more likely related processes, right? Thoughts or any questions about that? Did that make sense? It sounds like it does. Okay. All right. So, and then I'm going to go to Andrea afterwards. So this is her medical history, right? So she has no known allergies. She has type 2 diabetes, hypertension, hyperlipidemia, no past surgeries. She's not taking any medications. She was on medications previously. We don't know what meds they are. She doesn't really have any records with us, but she lost her insurance a year ago, and when she lost her job. So she lost her job, she lost her insurance. She has not filled any medications over the last year. So she also denies alcohol use. She smokes a half a pack a day for 40 years. What do you think is most relevant, Andrea, in her medical history?
I would say like the smoking could be relevant just because it was very prolonged, like she did it for a long time.
Yeah. Can you think of something that the smoking would cause that would potentially cause what's going on right now?
I'm not really sure.
What does smoking cause in general that we are all really worried about?
Like lung cancer.
Lung cancer, right? But does smoking cause lung cancer, or does it cause other cancers as well?
Like mouth cancer, like esophageal. Yeah, I don't know.
So yeah, it can cause mouth cancer, esophageal cancer. It can also cause bladder cancer and kidney cancer too, right? The toxins from the smoke, they kind of go everywhere and have to get eliminated somehow, right? So we do a lot of screening especially in men that smoke, to make sure that there is no potential for kidney cancer. Perfect. So any questions about that, Andrea?
No, that makes sense. Thank you.
Okay. Joey, any other relevant history that you would pick out from here?
I think it is relevant that she was on medication, at least for some amount of time, but she doesn't know what, so we don't really have much information on that.
Yeah, so yeah, we don't have much information, but what about that is important?
She could have had some like disease that's like chronic.
Yeah, and we know she has diabetes, hypertension, hyperlipidemia, right? So what about that is important, that she's not on meds right now?
It could just be like, or not, it could be, but she could have problems with her like uncontrolled diabetes or something like that.
Yeah.
Or hypertension.
Yeah, we don't know what her control is. She might have a really high blood pressure. She might have out of control lipids. She might have out of control blood sugars, right? Does anybody know if I say her lipids are really, really, really high, does anybody know what that can cause?
Is it hyperlipidemia, lipidemia, I think, something like that?
Yeah, hyperlipidemia is what it's called in general when you have really high lipids. But there is something, a disease process that can cause that we kind of talked about already. Does anybody know? Prem.
Can it cause an arterial blockage and then lead to an MI?
It can, well, yeah, over a long period of time, it can cause stenosis and cause an MI. And then if you think about stenosis in the heart vessels, you can also get stenosis elsewhere. And one of the things that may happen, it's easier to show you. It's not what I'm going for, but that's a good kind of learning point, right? You can get something like a mesenteric ischemia. Where the arteries coming off of the aorta and innervating the colon and the small bowel as well get blocked off. So you have blockage of the artery here, and it can, just like in the heart, you can clot it off, and then you have an area of ischemia. You have an area of gut that is dying that can cause pain. It can cause nausea, vomiting. A lot of times you will have blood in your stool, so that's kind of a negative for this. But honestly, I even forgot about this. So that's a really, really good point. That it's a process that can be going on. So I would actually add this to our differential right now too, especially if she's super uncontrolled. Okay, but that's not what I was going for. Fran, what do you think? Or I think who else had their hand up? Benia?
Hi. Since like you say that she has high lipid levels, she had like a history of like eating foods that have like a lot of saturated fats as well. It could be a cause of concern for like atherosclerosis, which could then turn into like angina or MI.
Yeah, that's exactly like what we were saying right now. It can be in the heart, it can be in the belly. It can even technically go into the renal arteries as well. So yeah, absolutely. Karen?
I would say if she has high it's like a elevated cholesterol level, then it can affect her GFR for her kidneys.
It can if it is narrowing her arteries to her kidneys and it's causing ischemia in the kidneys. But what if I say triglycerides? She has really high triglycerides. Does anybody know what that may cause? And so it's a disease process that we talked about today. So, Zaina, what do you think? Are you here in this chat? I don't know if you're actually in the meeting itself. All right, Joey, I think you.
Pancreatitis.
Yeah, pancreatitis, exactly. So, so really high triglyceride levels is a cause of pancreatitis. And so if you have somebody, and it's really cool actually, when you draw the blood, if it's high enough, you'll see like the lipids in the blood. Let me see, elevated triglyceride levels, blood draw. Let's see if anything pops up. Yeah, it can look like this, where you have the lipids actually separating out into the blood. And so one of my mentors told me like that's how he was able to catch a pancreatitis, because this patient came in with nausea, vomiting. They were thinking a bunch. I forget what his actual differential was and what the actual case was, but the patient wasn't getting better. They weren't thinking about pancreatitis initially, and so he went in to see him in the morning, and at that same time, the nurse was drawing the patient's blood. And he saw that it was kind of like this, where you had that milky fluid there too, because it was so high. And so he was able to diagnose hypertriglyceridemia as a cause of his pancreatitis. So yeah, it's something that you would want to think about. So the lipid panel being the lipids being elevated, the patient having uncontrolled blood sugars or uncontrolled blood pressure, that's going to be pretty important, just in general, because even if it's not directly causing the process going on, it may make it harder for that patient to actually get better, right? And so, Fatima, what do you think is going to be important on this patient's physical exam? Like, what would you want to examine first? Like, let's say I told you, okay, you have one area of the body that you're going to examine. Where would you go first?
This is just kind of a guess, but I know sometimes doctors like palpate the abdomen to see if there's like any tenderness.
Absolutely, right? So the patient is having, if we're thinking that the patient is having a potential urinary process going on, and we're thinking maybe also potentially in the belly with the ischemic bowel or pancreatitis, that would be the first place I would go to as well. Because if the belly is very hard and firm and inflamed, that would be a surgical emergency, and we need to call surgery right away, right? So fantastic job. Okay, Minal, where else would you want to examine?
Can we examine their back pain by asking them to stretch to see if it's more muscular than it is like infectious?
Absolutely. She came in for back pain, right? So you want to make sure that you look at the back, and it's not, I guess it's pretty much a stretch, but you test range of motion to see if there's any restrictions, if there's anything obvious there. That's very important. You can also test the nerves by the nerves going down into the legs by lifting up their leg, seeing if there's a stretch that causes pain. But yeah, absolutely. She came in for back pain, right? You want to make sure you check the back. Anything else that you want to look at?
I'm not sure.
Okay, Brianna.
I guess regarding her back pain, if it's alleviated by any motion, so like if we're looking at pancreatitis, if she leans forward, then maybe that like she has some improvement in her pain, and then that can either help us rule out pancreatitis or rule it in.
I don't know if I'm actually not sure. I have to think about it or look it up. I'm not sure if pancreatitis gets better leaning forward. A pericarditis might, but pancreatitis, I don't know. I'd have to look it up. I don't think so though. But the point of what may alleviate the pain is actually really important, right? Because if it's musculoskeletal and there's some movement that she does that may alleviate the pain, that kind of moves us less from like intra-abdominal pathology and more maybe a musculoskeletal issue. But okay, perfect. Let me see. And then I guess the other part of this, and it's kind of like a trick question, the other big thing that you want to do for the physical exam is going to be look at the vitals, right? Because vitals is technically considered part of the physical. We kind of separate it, but it's part of that objective information part. You want to make sure you look at the vitals more so to answer the question, is this patient sick or not sick, right? Minal, did you want to say something?
Yeah, I have another a question. So if she also has blood in her urine and like burning in the urine, when you do like a physical exam, would you also look at her vagina, do like a vaginal examination?
Yeah, you can. I would probably For this patient themselves, unless they're having vaginal bleeding, I probably wouldn't. But if you want to be thorough and if you know, it's all dependent on how much you actually trust the patient, right? If you trust the patient knows that this is a urinary bleed and not necessarily a vaginal bleed, then maybe not as necessary. But if let's say this patient has a history of dementia, it's not a really good historian, then I'd probably examine everything first. To be honest with you, I'd probably examine everything first, get some labs, and if nothing is adding up, I would then go for a pelvic exam, unless I felt something in the abdomen or something I was worried about. The reason being, pelvic exams are not very comfortable. They can be pretty painful, and if you have a confused patient, it may make it, they may get agitated from it. If you need to do it, absolutely do it. But you're talking about a speculum inside, opening up, seeing if there's any lesions, potentially using your hand to kind of palpate the cervix and move the uterus and see if you feel anything on the top of the abdomen. So if you can avoid it, better. If not, then, you know, do what you got to do, right? But that's a good thought. Okay. Let me see here. Okay, so let's move forward, and we're gonna go to Ashleen. So we're gonna just focus on the vitals right now, Ashleen. So blood pressure is 130/70, heart rate is 120, respiratory rate is 20, O2 sat is 97 on room air, and temp is 101.6. So first of all, is this patient sick or is she not sick?
I would say I would still lean towards sick. I mean, the heart rate does seem pretty elevated. I would say the respiratory rate, could be elevated. I think it's close to normal though. And the O2 sat is also pretty normal. I would probably want it to be higher, but I mean, 97 is still okay. Temperature also looks pretty high because it's over 100, or so I would say, definitely I would say sick.
Yes. And then what about her blood pressure?
I would say it's leaning towards elevated, but I wouldn't say it's super elevated.
What if I told you, well, yes, so you're 100% right, but she has a history of high blood pressure and she's not on any medicines, right? So what is something that you want to consider?
Pardon, could you repeat that? I missed that last part.
Yes. So she has a history of high blood pressure, right? And she's not on any medicines right now. She was in the past, but not any right now. So what would you want to consider based off of that information? So if it's possible, let's say she went to the doctor 2 weeks ago and we somehow, let's say a month ago, and we were somehow able to get those records. And her blood pressure at that time was 182/101. What would your thoughts be now?
I would say now it's pretty low.
It's exactly, it's low compared to what she was before, right? So that's why having that history is super important. And you know, you're not going to always have that history, so that makes it harder, right? So if she's a person that's running a systolic, the top number, the systolic blood pressure is in the 180s all the time, right? And now she's dropping down to 130, 120, 110, right? And that for us is normal, but for her it's not. That is something that you want to consider. And I think Mary said that on the chat as well. So absolutely. And the rest you kind of hit on his head. Like it's all right what you said. She's tachycardic, she's febrile. Her blood pressure for us is normal, but we don't know what her history is. So good job. Shadi. So she's ill appearing, in acute distress, dry mucous membranes, tachycardic. The abdomen looks okay. She has some tenderness to deep palpation of the left abdomen, some suprapubic tenderness as well, Cpa tenderness. She has hypertonicity of the bilateral paraspinal musculature throughout the spine. What in there is most important for you?
Probably the tachycardia, having like a higher heart rate.
Okay. So she's tachycardic, so that tells us that there's something going on. What about the belly? What do you think about the belly?
I'm not really sure what those really indicate.
Okay, good. So we'll talk about it. So she has tenderness to deep palpation on the left side of the abdomen and the suprapubic region, right? So let's let me pull this window. All right, abdominal. So if we look at just kind of general abdominal quadrants, that's too small. That's probably too small too. This is okay. So on the left side, she has some tenderness here, kind of like in this area. And then this says hypogastrum, but we call it the suprapubic region. So it's above the pubis. So she's having some tenderness here. If we look at the anatomy, so this is kind of like on that left side over here, you have your intestines, you have your kidneys, and then right here is your bladder, right? So that's where she's having her tenderness. Cpa tenderness is it's pain kind of at the costovertebral angle. So what that is at the angle of the ribs and the spine, right? So in this area right here, when you kind of do what this guy is doing, you're kind of tapping on that area. She's having some pain, and right underneath that area is your kidneys, right? So what would that tell you?
I guess it could tell us that there might be like some fluid accumulation in like the bladder, and that could be something with the kidneys.
Or inflammation, right? So just inflammation, because inflammation generally is what causes pain, right? So she has inflammation in that left side of the abdomen, in the bladder area, and around the kidneys. So taking all that together, what system are you more thinking about right now?
Probably the kidneys.
All right, that urinary tract system, the kidneys, perfect. So everything's kind of leaning towards that way. And then anything else on here that is worrisome to you?
I mean, it's just mainly the low blood pressure. Could be something like some bleed or something like that.
Yeah, you want to make sure you don't miss something like that. So yeah, and she looks ill. She has dry mucous membrane, so she's probably dehydrated. She's been vomiting, like we said, and she hasn't been able to eat anything. So that's going to be really important to make sure that she gets fluids in as well. So perfect. And then the hypertonicity of the muscles, it's not necessarily a huge thing. It's more there's inflammation there, and it's causing kind of like a spasm. She's having a lot of pain. You know, it may be her body's way of protecting itself, but range of motion is intact, so that's good. Hypertonicity itself, it just means that the muscles are kind of like spasmed. They're really firm. When you push on them, they're not like soft. Like if you were to touch your own back right now, if the muscles aren't contracted, the muscles are going to be softer. Hypertonic muscles are a bit more firm. Okay. And so we kind of talked about the top of your differential, but let's see. Anu, what labs would you want for this patient? And I think Jocelyn said, isn't pain on the left side indicate appendicitis? It's possible. Yeah, for sure. Okay. Manon, what labs would you want?
I would get a urine analysis, a culture,
Mm-hmm.
CBC, and a the other blood. I know it, but I'm forgetting a BMP.
BMP, perfect. Yeah, that's probably what I would get too. All right, let's go forward, and let me actually switch the screen again. So let's see here. Tasha, so I'm gonna have you look at the labs and interpret some of them for me, okay?
Okay.
So these are the labs. So the CBC has a white count of 28,000, hemoglobin of 10, platelets of 520, and BMP, sodium 140, potassium is 3.5, bicarb is 18, creatinine is 2.5, glucose is 630, A1C is 17%, lactic acid is 4.8, UA is positive for glucose, ketones, nitrites, and leukocyte esterase. So what are your thoughts?
Isn't the glucose really high?
Yeah, the glucose is super high.
And isn't the sodium high as well?
The sodium's normal.
Okay. So the glucose looks really high. And it says that the urine analysis is also positive for glucose, which makes me think that some of the pancreas suggestions we were talking about earlier, I'm leaning more towards that.
Yeah, I mean, potentially, right? If you have something that's destroying the pancreas and you have an abrupt loss of your ability to produce insulin, yeah, you can have really high glucose levels like that. But she has history of diabetes, right?
Oh, true. So it could also be. Maybe
she's
not. Could it be like she's just not treating or like keeping up with her diabetes well as well?
Yeah, she just might be super high because she's not getting any treatment for her diabetes. And then, do you know what the A1C is?
No.
So an A1C is a measurement of your blood sugars over a course of 3 months, right? So we can get a glucose and it'll tell us what the blood sugars are at that moment in time, or we can get an A1C and it'll give you an average. So what it is it is a measurement of glycosylation of red blood cells. So all that means is we look at red blood cells and we see A1C, RBCs. We see all the sugar molecules that attach to it. And so if you have high sugars in your blood, you're going to have more blood, we're going to have more sugars attached to the actual blood cells themselves. And so we look at that percentage. And the reason why it's an average over 3 months is because that's generally the lifespan of a red blood cell. So it's a really cool and straightforward kind of analogy with like a practical lab application for physiology. So yeah.
Okay. So since her A1C was high, that means that over the span of the 3 months, her blood sugar has been high as well.
Yeah, so that tells you, is this more of an acute for her glucose? Is this more of an acute process or a chronic process?
Chronic.
Okay, perfect. All right. Any other thoughts that you have? Anything else that you are looking at with these labs?
We're just seeing a lot of sugar stuff, but her lactic acid is also high.
Yeah, so what's the lactic acid mean?
I know that lactic acid builds up when you exercise and stuff like that, and it can cause like soreness.
Yeah, it can. So what happens? What are some other? So you have soreness. How would I put this? Okay, so lactic acid is present in pretty much all cells, right? It's part of that glycolysis cycle, and I'm really forgetting all of it. I think it's part of this. Is it going into the citric acid cycle or afterwards? It's going, right?
I believe so.
Right. I think if anybody knows, shout it out because I'm forgetting.
I think it's before the cycle.
Right, because that's that last end product, and that's because that's the one that you would be
for anaerobic.
Yeah, that's the word. Thank you. It's been such a long time. See, you don't really use this in med school, so I mean in medicine in general. So yes, so it is that anaerobic breakdown of blood sugars. It's what doesn't give you as much energy, but at least you have some to kind of get things going. So if you're not getting a lot of oxygen, right, because that's what you need to actually go through the electron transport chain and all that stuff. You're not getting oxygen, right? What would, and it would cause lactic acid to build up. What would cause that?
Well, it would explain her fatigue and stuff. So if you're not getting enough oxygen, I'm assuming the red blood cells aren't getting oxygen and it's not like transferring throughout your body.
But we also know that she is getting like actual oxygen into her body. She is getting it, right? She's getting 97% oxygen. That's good, right? But she's also not perfusing her tissues well enough, it seems, right? So she has enough oxygen coming in, but she's so sick that her tissues are not getting enough oxygen. That can cause damage, right? And cause breakdown of some cells, and it releases lactic acid into the blood. Does that make sense?
That makes sense. So could it be like liver or something issues, like causing lactic acid to be released?
We don't know, right? It can be anywhere in the body, right? There's other lab values, and this is kind of getting a little, it's just getting kind of a bit more into pathophysiology, and it's becoming a bit more complex. So if you don't understand something, that's okay. You can ask me, I'll try to explain it. But basically, when you have a overwhelming, process going on in your body, she is tachycardic. Her blood pressure may be low for her, right? She's not able to really perfuse things very well. Blood cells start to die, or they start to produce, not necessarily start to die, but they are starting to not be able to go through the citric acid cycle and electron transport chain, and not able to really get all that energy in because they don't have that oxygen to really go through that process. You're starting to build up lactic acid into the tissues. That lactic acid can leak into the bloodstream and cause lactic acidosis. And so that lactic acid is a way for us to see how that person is doing, right? If your lactic acid is high, that tells us, there's an overwhelming process going on. And lactic acid is an acid, right? It's this bicarb right here, that's your buffer in your blood. So if your overall acidity of your blood is starting to go up, the number of protons in your blood start to go up, your bicarbonate, the HCO2 in your blood is going to be used up to bring that pH back down to a normal level where your body will be able to function. Once that happens for a long period of time, your bicarb is used up, your acid levels are going to go up in the body, and that can be disastrous, right? So it looks like here she's not really perfusing her tissues very well. She has lactic acidosis because she has acid here. There's another component of this where she might have ketoacidosis because she has ketones in her urine and her blood sugar is so high. So there's a process called diabetic ketoacidosis, and all that is if you don't have enough insulin in your body and you can't use up the glucose, but you need energy, your body will start breaking down ketones and fats and into ketones, and that produces more acidity in the blood as well. And so that might be contributing to, just because your blood sugars are so high. So that's kind of getting into the weeds of what's going on here. But this is all to say that this patient is very sick, right? She's very, very sick. Okay, so let's go to John. Anything else in here pop out to you?
The UA is positive for glucose and ketones.
So yeah, glucose and ketones. A lot of times it's going to be with the DKA process that we talked about, and also her diabetes. Nitrites and leukocyte esterase are just markers for, nitrites are a marker for bacteria, and then leukocyte esterase is inflammation in the bladder. Let's see, Karen, I think you have your hand raised. So anything else pop out to you?
I would say the white blood cells are pretty high. Hemoglobin is a bit low, and platelets are pretty high.
Yeah, so the platelets, a lot of times that's just a marker of inflammation as well. But the white blood cell count is super high, right? So she has some inflammatory process going on, and it's pretty overwhelming, right? So absolutely. So with all of this, I mean, there's a lot of information here. What is your guys' diagnosis? What would you diagnose this patient with?
I would say some kind of infection because the creatinine is pretty high too.
Yeah, the creatinine is really high too. So I think somebody had mentioned about a kidney infection, very potential. If she's having sepsis, or sorry, if she's having I gave it away. Okay, if she's having a overwhelming inflammatory response and an infection that's causing decreased perfusion to her organs, that can cause damage to the kidneys as well. Okay, and so I mentioned it already, but what do you, Nassim? I think your hand is up. What do you think is going on with this patient?
Well, you mentioned sepsis, so I'm assuming it's that. But at the same time, like before you had said that, I was thinking, is this any like similar to like untreated diabetes? Because I know she said she had like a history of diabetes. So like, could any of this happen if left untreated in a patient?
It can. So that's the DKA that we're talking about, right? The diabetic ketoacidosis. So that is very possible. But yeah, so this, I mean, just in the interest of time, this would be considered sepsis because, and I think, let me see here. I think I have a slide on this. Yeah, so we look at something called the SIRS criteria. And this is a way to categorize the overall inflammation in a patient, right? So SIRS is just kind of gives us an idea, is this patient sick or not sick, pretty much. So if her temperature is greater than 100.4, which it is, or less than 36 Celsius, 96.8 Fahrenheit, which it's not. So she's above 100.4, her heart rate is above 90, her respiratory rate is 20, so that doesn't count, but her white blood cell count is above 12,000. So she would meet criteria. So you need at least 2 of these to meet criteria for SIRS. And so, and all SIRS means is it stands for systemic inflammatory response syndrome. That's all it means. So if this patient has evidence of overwhelming inflammation and she has a source for that inflammation that is an infection, that is then considered sepsis. So if you meet this criteria, but there's no evidence of an infection anywhere, they would just have SIRS. But because she meets this criteria and then she's showing signs of a UTI or even a kidney infection, then she meets sepsis. Does that make sense? It sounds like it makes sense. Does anybody have questions about that? Okay. Now, you then can categorize that syndrome a bit more. So we know she has sepsis now, but now when sepsis starts to affect the body and cause organ damage, you can call that severe sepsis, right? And a lot of those patients are very, very, very sick. So for her, she would categorize as severe sepsis because her lactic acid is high and she has a bump in her creatinine. We don't know what her creatinine was before, so we can't really say that, but we know her lactic acid is high. And so lactic acid, like we said, is a decrease of perfusion to her organs and it can cause damage. And so we know there is some damage there, right? So she met SIRS criteria, she has a source, and she has damage. So she is categorized as severe sepsis, okay? And this is a this is a topic that we can go way more in depth with. And if you're interested, we absolutely can. Just let me know. Nassim?
Do we know where it originated from?
Where do you think? Where do you think this originated from?
A great question. I'm just gonna go with the kidneys, probably.
Yeah.
Somewhere in the urinary tract.
Just think about what we know. Why did this patient come in, right? Because we're kind of getting into the weeds with the labs, and it's very easy to do that. But you take a step back and think about, okay, where did the patient come in? Or how did the patient come in? Back pain, dysuria, so burning when she pees, blood in her urine. She had belly pain. Her creatinine is elevated. And she has uncontrolled diabetes, which is kind of may or may not be a red herring. But all of these things are kind of popping up. And she meets this syndrome for sepsis and severe sepsis, but that's not a diagnosis in and of itself. You have to say, why is she having that, right? And just like you said, her urinary tract is probably the source, right? So again, in the interest of time, we'll kind of just move forward, okay? So this is a clinical course. So the patient was admitted to the ICU for severe sepsis secondary to pyelonephritis and questionable DKA. I would say she met the criteria for that. She was started on fluids, ceftriaxone, which is an antibiotic, and insulin. Her blood sugars and acidosis improved with the insulin and the fluids, but she remained febrile. Her blood pressure continued to fall despite really high volumes of IV fluids. Her kidney function continued to worsen as well. And her urine culture returned 36 hours later, positive for E. coli, which was sensitive to the ceftriaxone. So we know that the bacteria that she had in her urinary tract was being treated by the ceftriaxone, by the antibiotic. So what would you do now? What would you want to do at this point? And anybody can answer.
Would you want to give her antibiotics for the E. coli?
So she's already on them, right? She's on the ceftriaxone, right? So, and it seems appropriate. It looks like it's supposed to be treating it, but she still looks like she's getting sick. So what would you want to do?
Would a steroid help?
Probably not. But for this patient, probably not. Sometimes with lung infections, steroids may help get better, but for other bacterial infections, a lot of times it may make it worse. So, and then her blood sugars are so high, they're better now, but that might throw her out of whack as well.
Dialysis, but her levels seem to be getting better, but I don't know if dialysis would be a good option.
Probably not if her kidney function, we said, is worsening. So potentially, it all depends on what her indication is for dialysis. So there's a whole criteria on it, and we won't go into that right now because it's a whole separate lecture. But if you guys are interested, I can talk about it a bit more later. But not necessarily dialysis. So she has something going on, but we don't know what it is, right? So what you got to run more tests. So what tests would you want to look at?
Can we get radiology for her abdomen to see if maybe there's still a stone? Like maybe there might be a stone that's causing her to still be sick.
Absolutely, right. We don't know if she had a stone. We don't know what's in that urinary tract because we didn't get any idea of what's in her abdomen. We just started treating it, which was appropriate, right? With what was going on. So absolutely. We don't want to get some imaging, see if there's a stone, because if there's a stone and things aren't able to drain, well, you're not getting anything out, right? You're gonna have, basically, it's kind of like an abscess. Things just aren't getting better because they're staying in there. They're not able to drain out. So absolutely. People on YouTube are saying insert a catheter, switch antibiotics. The catheter may help just to see what her urinary output is, but if she's peeing okay on her own, that's okay. Most of the time, though, if they're in the ICU, they'll have a catheter in. Switch antibiotics, I probably wouldn't, because if it's sensitive to ceftriaxone, then you're pretty certain that you're supposed to be treating it. Depending on how sick she is, you might want to get other antibiotics on board just in case, but you know that the E. coli is responsive to the ceftriaxone. Perfect. So we said imaging. This is the imaging that we get. We get a CT scan of the belly. Does anybody see anything there?
I think, is it her right or left kidney? The one that with all the black area, it doesn't look right.
What is black on a CT scan?
Is it air?
Air, right? So she has air in her kidney. Why would she have air in her kidney?
Is her kidney like being, I don't know, like is the tissue being eaten away or something? Like disintegrating? I'm not sure how like describe it.
Yeah, that's what happened. Her kidney was literally being eaten away. What would cause that?
Is this from the E. coli present? Like that because she tested positive for E. coli?
Yeah, but why? Does E. coli UTIs are very, very common. It's the most common cause of UTI. Why would this happen to her? And does anybody know what this is called?
Is it because the UTI went untreated and then caused sepsis, and then the sepsis is leading to the kidney tissue dying and being damaged?
Not necessarily, because you can get with any pyelonephritis, you can have severe sepsis, right? It doesn't necessarily cause damage to the kidney like this. That was a good thought. Because she does have severe sepsis. Other thoughts? Anybody know what this is called? And if you're not sure what we're looking at, this right here is that left kidney. This is the right kidney. The right kidney looks great. It looks pretty good. I don't see anything wrong with it. You don't ever want to see black like this in the kidney. Over here, this is kind of this is the intestine or the stomach. And so in the stomach and the GI tract, you can see air. It's not a problem. But outside of the GI tract, you don't want to see that, right? So that's the kidney on the left here, and that's on the right. I think Camila is on the right track. I don't know. If you're in the chat here I don't see your name here. Okay, so in the interest of time, this is called emphysematous pyelonephritis. Okay, all that means is that you have air in the tract where you are in the kidney where there's not supposed to be air, and it's because of an infection in the kidney. So Minal, you said emphysematous pyelonephritis. What usually causes that? What do you think might cause that?
I want to relate it back to her labs. Is it because her creatine was so high?
Nope, that's just kind of a sequela of what's going on with her kidney. Karen, what do you think? What can cause emphysematous pyelonephritis?
I would say the E. coli.
The E. coli, but there's something in her history that makes her more likely to get it. And we've been talking about it this whole time.
Is it because she's diabetic?
Yeah, it's her diabetes. And it's because her diabetes is so out of control that it caused this infection to be like this, right? So she was diagnosed with emphysematous pyelonephritis. Urology was consulted, and she underwent left-sided nephrectomy. So we took out the entire kidney, okay? She quickly improved, was transferred out of the ICU at post-op day 1, okay? Continue on antibiotics, all that stuff. But you basically needed source control. She had this infection in the kidney that wasn't getting better. The kidney was being destroyed by the bacteria. And so you needed to remove that kidney for her to actually get better. Okay. So this patient was extremely sick, and the actual clinical course was a lot more complicated. We for a while, we were kind of going back and forth within the team itself between like a very severe cholecystitis versus a pyelonephritis. So an infection of the gallbladder versus the kidney, but it just did not make sense. We got a chest X-ray first, and then an abdominal X-ray as kind of like the first screening. And it was missed on the abdominal X-ray that there was a very slight, and it's very, very faint, very easy to miss. There was like a black speck where we thought, okay, that's, when we looking back, we said, okay, that, you know, it makes sense that that might have been the bowel gas and not necessarily the kidney. But it was kind of right at the beginning when she was admitted that we got that. And so for like a day or two, we didn't know what was going on until she just wasn't getting better, and we got the repeat imaging, and it showed this air in the actual kidney itself. And after that, we were able to treat her, and she did better. But it's something that's not super common, very easy to miss. But when you have a patient with very uncontrolled blood sugars and infection like this, you can have destruction of the kidney. And so Impulsiveness pyelonephritis is fatal if it's not treated promptly, and it almost always requires surgery, though right now that's changing because interventional radiologists are now able to put in drains and help drain out the kidney a lot easier as we treat it with antibiotics. So you get a little bit of that source control there. In the end, though, if they're not getting better because they're so delicate and so they're so sick and they may crash pretty quickly, you have to treat this and be vigilant. Most cases develop because of uncontrolled diabetes. Some may also develop because of urinary tract obstruction, so like what we talked about with the stone. So basically the glucose is fermented by the bacteria, and that's what causes the gas. And you're able to run rampant with the bacteria because the high glucose levels sometimes impair immune function. You might see this in patients that have impaired immune function because they're on immunologic medications for something like psoriasis or an autoimmune disorder where you're kind of suppressing the immune system, or even in organ transplant patients as well. And then the hyperglycemia just allows the bacteria to run rampant as well. You can see this on X-ray, kind of like what we talked about, but CT scan is more specific and sensitive of a test. So any questions about that? I think there are some hands raised, but I don't know if those are actual questions or not. If they are, just feel free to shout out.
I have a question.
What's up?
So, like, how do you, like, I know that you're saying that the diabetes, like, was helping the kidney deteriorate, kind of, right?
Yeah.
How do, like, for regular diabetic patients, like, how do you prevent that? Because, like, I know, like, for diabetic patients, like, sometimes, like, their urine holds more glucose in it.
Mm-hmm.
So, like, how do you prevent that from happening?
It's if you have a little bit of glucose in your urine, that's not the problem, right? The problem is when you have such a severe elevation in your blood glucose that you're basically just giving fuel to the fire, right? You don't necessarily see this in uncontrolled diabetic patients with just a mild elevation in their blood sugar or A1C. Even at like A1C levels of 10, I never see this. And for the most part, people get treated a lot faster. So yeah, it's not necessarily like every patient that has uncontrolled diabetes and a UTI that goes into a pyelonephritis. Not every patient will do this. Otherwise, it would be a lot more common, right? Because uncontrolled diabetes is pretty common. And so is a UTI, so is pyelonephritis. So it's in those specific patients that have very, very severe discontrol of their blood sugars that this happens.
Yeah, because I work with the urologist, and almost like a lot of his patients with diabetes, they have a nephrectomy done. So that's why I was wondering, like, if that's related.
It depends. If they have a nephrectomy, that might usually. I mean, even with an infection, you don't get a nephrectomy because of an infection unless it destroys the kidney like this, and they wouldn't get it. They would get it more inpatient when they're really sick. I'm not sure why they're getting nephrectomies. It might be for a lot of other reasons. But even with like chronic kidney disease because of diabetes, where you have where your kidney gets so damaged that you end up needing dialysis, you don't necessarily need a nephrectomy. So I'm not sure. I'm not sure about that. Other questions? Okay. So I think that's the case. Yeah, so that's the case. Now, a question to all of you. Do you prefer, because this is, of course, a lot more challenging than what you guys did the last 2 weeks. Do you prefer something like this, where we kind of have more variety in what we're doing, or would you rather practice more of the cases more related to chest pain and then eventually abdominal pain? Like, what would you guys prefer? You can put it in the chat. You can shout it out. Either way is okay, because it makes it a lot easier to bring more interesting cases if we're kind of just doing something like this. And I'll keep putting information out and things for you to watch so you can learn, and it'll actually help you with the cases going forward. Okay, switch it off like this, like what we did today. You learn a lot. Variety is fun. Okay, perfect. And what I will do, it looks like everybody wants more variety. What I will do then, I'll keep it kind of like this. I'll keep teaching you guys about different organ systems, keep teaching you about giving you different tools to help you along the way, but it'll be more unknown like this. That way, and then it makes it more fun for me because I have a lot of really interesting cases that I can put together. So, cool. We'll do this then. Okay. Any other questions? I'm going to put you guys into your groups and everything like that. Feel free to send me any messages if you have any issues. And that's all I got for you today. So, yeah, take care, guys. I'll stay on until there's no other questions.
Thank you.
No problem. Cool. Have a good day, guys.
Thank you.
I have a quick question.
What's up?
So you said you'll put us into groups. So this is my first virtual rounds that I do like out live. So what were you meaning?
So what we're gonna do, just so that we have more kind of collaboration, I'm gonna add you guys all to my teams, and there'll be documents and stuff hosted there. And then you're gonna all be put into a group within those teams. And this is more for us to have, like we kind of talked about in the past, to have like competitions with Kahoot. So each team is going to be working together to try to get the highest score on Kahoot. We'll keep doing these cases and all that. And then it'll also give you a group of people to kind of run things by, talk things through with. I might be posting practice cases before our session, so that way you can practice and work things through and keep working on those differentials and all that. So it just ends up being that group that you can rely a bit more on. So that's all I mean. And then in the future, we may be using those groups for the humanities and medicine internship. So that is not decided yet. I'm still trying to figure out how to get more people involved without overwhelming the system, because I know a lot of people want to do that program. So does that make sense? Any other questions about that?
Yes, it does. Thank you so much.
Cool. Other questions that you guys have? All right. Then I think we're good for today.
I have a quick question.
What's up?
How would we, like, I know you said that we could tell you if we want to be with like specific people. So do Instagram DM you, or like should I email you?
So what I will do is I'm gonna add you guys all to Teams, and then I'm gonna probably put a sign-up sheet within Teams, so that way you can kind of put yourselves into groups. So if you have people that you know and you want to work with them, we'll put it. You'll basically put your name on the Excel document that I'm going to put on Teams. That's pretty much it. And then from there, I'll put everybody in their respective group.
Sounds good. Thank you so much.
No problem. Other questions? I think there's one in Scholarly Course. Is there a way to make the questions in order so that they fit with how we think about the case? Are they going out of order?
Yeah, they're like especially today's, it's like you can't go on to the next question until you finish the first question, but they're like out of order. Yeah.
I need to change that. I forgot to put it as a set order, so I will I'm gonna change that right now. Once we're done with this, I'll change it. It's just I forgot to click the button. Sorry, but I'll do that. But the other course stuff, that's been fine, right?
Yes, like last week's it was out of order, but it's okay because it was all on the same page. So you could just like scroll down.
It's still annoying. Okay, I will fix that. Okay, other questions? Cool. All right, you guys take care.
Thank you. Have a good day.
Thank you. Have a good day.
Bye.
Thank you. Have a great day.
Thank you.